Well, good morning, everyone. For those of you who I have not had the pleasure of meeting, my name is Ruby Nguyen, and I am coordinating our epidemiology and community health seminars this year. I am actually just keeping the chair warm for Rachel Whittam, who is going to be taking over starting in the fall. Hi, Jeff. If you are wondering why I'm positioned like this, it's because the camera is positioned for Dr. Rosser, and he is much taller than I am. So Jeff told me that if I wanted to be in sight, I needed to get taller very quickly.
In frame.
In frame, that's exactly right. I am in frame by being perched on this chair. So it is my distinct pleasure today to introduce all of the speakers. It is unfortunate that we can't see them in person. We would love to be able to collaborate more and speak with them in person, but we're so pleased that they're able to join us via Zoom. So thank you to Zoom for these types of opportunities. First, Professor Simon is a full professor in epidemiology and community health, a licensed psychologist, and a sexologist specializing in sexual health research. Simon leads a program of research called the Sexual Health Research at the University of Minnesota, or SHRUM program. He was one of the first researchers to evaluate HIV prevention and intervention for MSM, men who have sex with men. In addition to the grant being presented today, his current NIH R01 grants include a study of sexual rehabilitation of gay and bisexual prostate cancer patients, a study on how to recruit LGBT cancer patients, and a study to evaluate the effects of a training program to train nursing staff in care of LGBT seniors with dementia. So quite a wide portfolio. We're so happy to have him here. Professor Simon directs the sexual health minor at the University of Minnesota and teaches the sex, sexuality, and sexual health and sex health and HIV courses at the University of Minnesota. He is also a highly recognized instructor and educator. And he is also the co-PI on the Training for Health Professionals study. We also have, in addition, 3 speakers who will be joining us via Zoom. Our second presenter is Dr. Lucy Mgopa, MD. Dr. Lucy is a psychiatrist working at Muhimbili Hospital in Dar es Salaam. She is faculty in the School of Medicine, and she is a co-investigator on the Training for Health Professionals study. Her areas of research include studies of intimate partner violence, sexual abuse, and healthcare for key populations, including men who have sex with men, transgender, and sex workers. I would really love to meet you in person someday. Third, Mr. Gift Gadiel Lukume is also from the same institution. Gift is a midwife and teaches midwifery in the School of Nursing. He serves as a co-investigator on the Training for Health Professionals study and also as the project coordinator. In addition to running the study, he published a paper recently focused on community myths and attitudes towards sexual health in Tanzania. Fourth is Dr. Dixon Ale Makoka, also from the same university in Dar es Salaam. Dr. Dixon is the Dean of the School of Nursing. His research areas include research on nursing and midwifery, student education, and policy. He lectures in critical care nursing, and with Professor Simon, he is the co-principal investigator of the study. So welcome you all. Welcome to those on Zoom, both our attendees and our speakers. Professor Simon, thank you. He doesn't need the chat.
Well, good morning to everyone in the room, and good evening to those of us joining in from Tanzania. It's great to have everyone here. I know it's dinner time for some of us, and we do appreciate you giving up dinner for the occasion. I'm really excited to be here and excited for today for 3 reasons. First of all, I think you're going to agree that we've got some really exciting results, some of the best in my career. And it doesn't always happen. And when it does, you know, it's kind of nice. The second thing is that we're going to be talking about a collaboration between our university, University of Minnesota, and Muhimbili, University of Health and Allied Sciences. And reflecting that collaboration, we research together, we analyze our results together, and we present together. Third is, we recently had a meeting in our Division of Epidemiology, and a special welcome for those of you who may not have been to the division before. We're glad you're here. In our division, our studies in Africa is one of the best kept secrets. We don't share it with just anybody. That's a very Minnesotan thing, I think. But I do want to just highlight that in addition to the work that we're doing, we've got Shalini, who's doing some wonderful work in cancer, Hilly Searle in malaria in Southern Africa, Drissa Toure in doing maternal child health. We've got Horacio Duarte, who's in the room, doing HIV modeling. Kristen Mark has joined us from family medicine this morning. Good morning, Kristen. And we've got to give a hand out to her. She's just got her first R01 study to do the trans abilities and disability study in Africa. And we're very excited, and we'll be closely collaborating. And then also Jen Connor at the in family medicine is researching female genital mutilation or female genital cutting. And so it's great to see this. And part of my role, as you'll see later today, I'm going to be challenging you. If you're not doing research in Africa, I'm going to want to know why. So that's an open challenge to all my colleagues here today. I do want to acknowledge that training for health professionals, we're very grateful to the NIH, the National Institute of Child Health and Human Development, for funding the study. And as NIH requires, the opinions expressed here are strictly those of the authors and do not reflect the official views of the National Institutes of Health. I also want to dedicate this 5 years ago when our team was here. We started this work at the invitation of Dr. Sibelda Lishabari. She was the co-principal investigator and our study mother, and she died during COVID in Tanzania, and we miss her dearly. There's a beautiful sense of family when you're doing research in Africa, perhaps more so than the US. And she really, I think we all still miss her today. So with that, we're going to turn to the start, and I'm going to turn it over to Dr. Lucy. Lucy, would you like to lead us?
Yes, Prof. Thank you. Am I clearly audible?
You're perfect.
Okay. I think I've been introduced. My name is Lucy, and I will take you on the first part of the presentation today. So I'm going to talk a bit about Tanzania for those who have not been here before. This is one of the Sub-Saharan African countries, which is located in the eastern side. And we are bordered by the Indian Ocean and Kenya on the east. We are also bordered by Uganda and other countries like Rwanda, Burundi on the west, and the DRC, as well as Mozambique on the south. Second to Ethiopia, our country is led by a female president known as Samia Suluhu Hassan. Our population is around 63 million as of year 2021, and majority of this population is comprised of women. The median age of our population is 17 years, and most of the people reside in the rural areas instead of urban. The World Bank classification has classified our country under the low and middle income countries. However, most of our population live below the poverty line, earning less than $1 in a day. We depend mostly on agricultural activities for income generation. And luckily, we have about 121 tribes in our country. Each of these tribes has its own native language and traditions and customs. So these traditions and customs are passed on from one generation to the next. You will realize when you visit Tanzania, each individual you meet may have their own customs. We have a common national language, which is Kiswahili, but majority of us speak English because we use English as a means of communication in our education system from junior high to university. Next slide, please. what is interesting about our home is the tourism. We have a number of national parks, beautiful sceneries, lots of animals that I guarantee you would rarely find in other African countries. We have national parks like Serengeti, Tarangire, Lake Manyara, and good historical sites like the Ngorongoro conservation areas. So I think this is one place that you would never want to miss in your lifetime. And next slide, please. Again, Ngorongoro Conservation Area is also a site for history. It's a birthplace for the first human species where Olduvai Gorge is located. So I think I would invite you all to come here. But again, the next slide is going to explain more about the beauty of Tanzania, which is the beaches and the islands. Zanzibar. I think a lot of you in the room or those in the Zoom have heard about Zanzibar or probably have visited once. And Professor Simon will acknowledge this. The first time he came here, he visited Zanzibar. This is the place where he learned his basic Swahili, although he's very poor in it right now. But Prof, you have a whole team of investigators here who will be willing to teach you Swahili for free. So feel free to ask. Next slide. Okay, so apart from the stories about Tanzania, let's get to the real thing. That's why we're here today. Like similarly to other African countries, Tanzania faced a lot of health predicaments, and sexual health is not excluded. We have high rates of HIV as well as STIs. And the youth is also among the populations that are highly affected. And apart from that, most of them do not have accurate knowledge about prevention of HIV or other STIs. There are a number of sexual health problems that are affecting our communities in the country, including abortion, which of course is illegal in Tanzania. And we have erectile dysfunction affecting majority of men, female genital circumcision, child marriages, which of course results to teen pregnancy and complications of teen pregnancies. And we also have sexual violence affecting both women, children, and male. And lastly, we have also health concerns that are related to sexual health, including same-sex relationships and sex work. Now, we cannot deny that these two are common in our country, but the laws around it are very challenging and difficult, making healthcare services to these populations extremely difficult. And on top of that, sex work and homosexuality is highly criminalized in our country. So you can imagine the outcomes. Next slide. Now, apart from all that, most of healthcare providers, including us, some of us before we started the training of health professional study, we had no training at all, or some of us had little, and this is very common to the healthcare providers in our country, both in rural and urban, because it's a taboo talking about sex itself and sexual health as well. So it's very rare to find a healthcare provider, be it a midwife, a nurse, or a doctor, to ask a patient about their sexual health at any point in time. It's off limits, and most of us, we are raised being told that you're not supposed to talk about it, or rather you're not supposed to have sex until your marriage. So there are a lot of values that are going around the topic. Next slide. Now, our study site is MUHAS, which is Muhimbili University of Health and Allied Sciences. That was the name that was created after MUHAS was separated from the University of Dar es Salaam. Prior to that, it was a college when it was established in 1963. It's located in Dar es Salaam. It's a beautiful, beautiful university. And most of the doctors in Tanzania have trained under MUHAS. We had only one campus for years, but now we are opening a different campus somewhere in the western of Tanzania. We have different schools, School of Medicine, Nursing, Dentistry, Public Health, as well as School of Pharmacy, and two institutions, which is Allied Sciences and Traditional Medicines. We have more than 306 academic staff and closer to 4,000 students from each courses. Next slide, thanks. Now, in 2016, Professor Michael Ross and Dr. Sebalda, the late Dr. Sebalda Reshabari, invited a team of experts from the US, including Professor Simon, Professor Maria Trent, as well as Professor James Wadley from the University of Lincoln, to come and train some of our students on sexual health education. We had few students from School of Nursing, which comprised nursing students and midwifery students. And it was a very interesting training, and the students enjoyed it. They accepted it highly. It was very feasible. And we thought that it would be nice if we tailored it in our cultural context. And from there, because it was around summer when they came around Tanzania, I think Professor Simon could not sleep well. And so overnight he thought about the grant. And then that's when THB came into life. So I'm gonna give my blessings to a second presentation. Gift, if you can take over. Thank you.
Yes, thank you very much, Dr. Lucy, for the nice presentation. As I was introduced earlier, my name is Gift Lukman. I'm a nursing lecturer, Department of Community Health Nursing. I'm also the co-PI and also the co-investigator and the coordinator for the THP project. The project is NIH funded project, which is 5 years project with 3 aims. And aim 1 is all about conducting a socio-ecological need assessment of the sexual health care delivery in Tanzania. Aim 2 was to develop the sexual health curriculum and ensuring that it is culturally tailored to Tanzanian context. And aim 3 was to evaluate the effectiveness of Tanzania-based culturally appropriate sexual health curriculum. So I'm gonna take you the summary of the aim 1, 2, and the methods in general. And then Professor Rosa will take through the results of the all aimed as I was talking about. For the aim 1 in 2020, we conducted a formative research in Dar es Salaam, whereby we had 18 focus group discussion with 121st healthcare professionals and students. We also conducted 12 in-depth interviews with sexual health stakeholders. So the focus group discussion were stratified by discipline and working experience in years. We used the semi-structured interview, and all moderators and facilitators were bilingual. And our interview took about 60 to 90 minutes. Next slide, please. So the healthcare providers and students were asked about the sexual health problem that they come across often when they provide care to healthcare clients, their clients. So they listed 8 sexual health problems that their clients talk with them most. They started with HIV, AIDS, and sexual transmitted infection as number 1, and then they ended up with the sexual societal issues as the least one. Nurses and midwives, they were more likely to report seeing a patient with sexual health or sexual violence, while medical doctors and students were more likely to see a patient who have a sexual dysfunction, specifically erectile dysfunction. Next, please. So the other thing that we found is stigma. And this stigma is impacting negatively the healthcare to key population. In this context, providers who care key population friendly, they were labeled by other healthcare providers that they are also KP. That's why they do provide care friendly to KP without caring. But also clients who are KP, they fear talking with their providers about their problem because of the experience that they had from other healthcare providers when they talk about it initially. Next. So we also have 6 case studies in which we asked the healthcare providers and students how they would normally handle those cases at their clinic or hospital. So case number 1 was about a female victim of an IPV. And then the case number 2 was about a man with a rectal gonorrhea. And then we have a case about a teen who masturbates, and then a 14-year-old girl who wants contraceptions. And then we have a 9-year-old who have been sexually abused by a relative. And then we have another case, which was the last one. It is a middle-aged man with rectal dysfunction. Please. So a key results for M1, lack of training leads to poor clinical practice. So across all the 6 cases that I've shared with you earlier, without the training, providers are uncertain on how they can handle those sexual health problems or concerns. And also they are more likely to provide or to offer medically and scientifically wrong information when they are counseling or they are dealing with their clients. And they also fail to follow legal procedures when dealing with cases, for example, rape case, and especially in a low-resource country like Tanzania. Next, please. So with 12 ideas that we had, stakeholders identified common 10 myths and misconceptions in Tanzania, which perpetuate poor sexual health care. These myths and misconceptions, they were on family planning, vaccine, unprotected and unintended sex, sexual health education, and wrong sexual health information that they do provide their clients. Another slide. So after that, we went to AIM2, and in AIM2, we conducted a 60-step approach to tailor our sexual health curriculum to be Afrocentric. So we started by reviewing literature on the major sexual health challenges in Africa. And after that, we conducted a focus group to identify the most common sexual health problems seen or suspected in the clinic. And then we interviewed the community leaders to identify barriers and common sexual health myths and misconceptions. And after that, based on the results that we got from the focusing group and the individual interview, and then we designed a curriculum focused on those problems. And then later, just to make sure that we increase our acceptability, all the material were bilingual. I mean, we have material in English version and then in Swahili version. And then to make sure that they are culturally responsive, all modules were written by and then delivered by Tanzanian faculty. Another slide. So we delivered our curriculum in 4 days. Day 1 was all about the sexual health across lifespan, and then the sexual dysfunction. And day 2 was all about the addressing key population, LGBT and sex workers, the sexual violence in Tanzania. We had a focus group. We have group discussion, a small group discussion, the panel, and then the presentation. And then in day 3, we had a clinical assessment and counseling skill boot camp and how to write policies related to sexual health. And then the day 4, which was the last day, we had a sexual assault, NGO group working in sexual health, then cultural considerations, and the sexual health. So those are the 4 days with what was taught in every day. Next, please. So our curriculum format, we had lectures, presentation, we had panel, and here we had LGBT panel, and then we have small group discussion, we had video, and then we have role play during practice session, we have small exercise and gaming, and then we had question and answer sessions at the end of each presentation. Next, please. And then we had a pilot that we conducted in 2021 that involved 25 students, medical students, midwife. And then what we have seen there, we have seen a big increase in the knowledge, and then we have seen an increase in the comfort during discussion, especially when they are discussing sexual health issues with their clients. Another slide.
Okay.
And then here yes.
No, carry on.
Oh, and then here in M3 now, we recruited 412 students, whereby at baseline, all students, they had to fill a survey, and then they had to go to 2 standardized patients just for interviewing the standardized patients who have a sexual health problem. And then after that, we grouped, we have 2 groups, an intervention group, which was 206, and then the control waitlist group, which was other 206 students. And then the intervention group, they were trained about sexual health curriculum in the same year. And then after 3 months, both of them, I mean the waitlist control group and then the interventional group, they were followed up to make sure that we see if there is any changes of the skills, knowledge, and attitude based on the group which was, I mean, taught the sexual health curriculum, and the other group which they were not taught the sexual health curriculum. And then later, after 12 months, we trained the waitlist group, the same material that we used to train the intervention group. Thank you very much for your attention. Now from here, I will let Professor Ross to go on with the significance of the studies and the results.
So sometimes a good night's sleep when you're doing this kind of work, you wake up in the morning and you suddenly think, why the heck aren't we funding this and doing a study? So we wrote the study, we got it funded by NIH. I'm not the best at actually reviewing the literature, and I didn't realize that this is the first randomized controlled trial of a training for medical and nursing students ever anywhere on the planet. And so that would have been really nice to put into the justification for the study. We've now done that for the second one. So it's the first rigorous study of a curriculum tailored for an African context, and it's the first study of a sexual health curriculum effects on knowledge, attitudes, clinical skills. We had a bunch of hypotheses, but those of you more used to biological designs, when you're doing behavioral research, we typically talk about increased knowledge. Attitudes are really important because we know that they motivate people and they affect that. So finding a way to measure that. And I want to just do a shout out to Dr. Michael Ross and our team who did a whole lot of validation of attitudinal scales so that they were appropriate to Africa. And then for clinicians, the bottom line is, do we improve clinical skills? Are we producing superior clinicians? We have a bunch of secondary measures. I'll go through those when we go through the results. And secondary questions. We wondered if this would vary by health discipline, because we've got midwives, nurses, and doctors. Maybe it has greater effects in one group than another. We have gender issues, males and females. There's a bunch of research that suggests that one gender may be more comfortable talking about sexual things than another. And by religion, this is part of the world where Christianity and Islam are the 2 dominant ones at this particular university. We'll talk more about others. And then, does cultural and personal acceptability vary? And that's really important because you can produce the best curriculums, but if it's not culturally acceptable, then you've got real problems. So data and analyses were assessed through, sorry, this is a mistake. It's online surveys skills development. We used simulated patient videos. This is something that is popular in the US, but very novel in the African context. And this is happening during COVID. So we would have the student assessing the counseling over laptops for safety reasons. And then the analysis is repeated in others. Just to give you an idea of the demographics, we ended up having relatively few midwives, so we collapsed them into the nursing group, and contrasting that with the medical. We're mainly talking about latter year students in their ultimate year or penultimate year of training, and that's because they're out in the clinics, they've got a chance to actually practice the skills. The average age, as you imagine, this is a young country, but similar to our medical school, about 24 years old, and the gender, we have a good range there. When we look at relationship status, almost all these students are single, which is culturally, the students, few were married. Nobody was married polygamously, which is legal in Tanzania, and very, as contrasted to the US, very few cohabitating with anyone or admitting to it anyway. In terms of sexual orientation, a large amount of people identifying as heterosexual. This is before the training. We took the things, and some of these terms may not have been well understood or understood in a different way. So a very large number of asexuals, and given the that homosexuality is illegal, it's not surprising that you get very few people reporting information that could land them in jail. And as I said, you see the dominant religions there. This is something we're really proud of, and I want to give a shout out to Jift, who's an amazing project coordinator. Somehow, I've never had 99% retention. That's helped by the fact that the students and that they're a captive audience and that you know where to find them. But it's still, it's better than I could have hoped for in an American university. And part of it, we think, is the students really appreciated any opportunity to learn. The only students who dropped out, it was for health reasons. We had a COVID protocol in place, and not everyone could manage that. So let's take a look at the results, and I want to orient you. I'm going to go just through the observed results because they're easier to graph and show you that, and then I'll show you the analytic results. Just to help you understand the slides, on the right-hand side is how we're measuring. On the left-hand side is the results. And for knowledge, we tailored that to the curriculum, right? Because you want to find out whether the people actually learned the facts that you were trying to teach them. And what you see here is the control is in yellow. The intervention group, you see a large increase in knowledge, which is sustained at 3 months. For attitudes, the core attitudes that we thought is, do these people feel confident in their ability to discuss sexual health? Again, you see similar results. You see a large improvement in attitudes or confidence in the intervention group. You see no change in the control. Similar results for confidence of their sexual health knowledge. Do I feel that I'm actually a competent physician, knowing same sort of thing? When we come to actual skills as assessed, this is where the blinded part of the study comes in. So skills were assessed with simulated patients, and that's where you get these actors come in and they consistently report and they assess the student, but then we had faculty blinded to whether or not this was pre-test or post-test, blinded to whether or not they're in the intervention group or control group, just rate all the videos. And what you can see here is the videos were only done pre-test and then follow-up. And what you see is an intervention on actual medical history taking and being able to take a competent history improves dramatically, and interpersonal communication. So the intervention group is able to talk with patients about this and communicate and in a way that the control group couldn't. In terms of secondary results, there is a question about what to write in the patient record, whether patient records in some institutions we heard where they've got a different, less controlled approach to record keeping. So if you want to find out what's in your medical record, you can always ask somebody to go to the hospital and look it up in some ways. So we were concerned that information that could harm a patient might get put in there. And so, for example, items like if a woman says that she had an abortion at 14, what should you write in the record? What shouldn't you write to protect the patient? And what you see here is, again, a large increase, which is sustained at 3 months. And the effects on knowledge of mandated reporting. There are certain patients who need to be required by law to be reported, e.g. a child who has been sexually abused. And what you see here again is in the intervention group, you see a large increase at post-test, immediate post-test, that they know a lot more about who should and who shouldn't be reported, and it's sustained at 3 months. We also see a slight decrease in the control group, and that might have been a contamination effect, that the people in the control group are suddenly getting less sure because their colleagues are learning this information and they don't yet have access to it. Effects on knowledge of professional ethical standards. This is something that Dr. Lucy developed a segment on, and it's, if two 16-year-old students are being sexual, should I report it to the headmaster or shouldn't I? Those sort of professional ethics, and again, you see a lovely increase. Finally, the effects on sexual health beliefs. This was an unanticipated result. Very genuinely, we are interested in improving students' clinical skills, their abilities, their knowledge. We're not about trying to change people's politics, but there happened to be a scale in the SHEPS, which measures whether people tend more conservative or liberal. We actually see a change towards the intervention group having more openness, liberal attitudes. This could be influenced by some of the facts that they learned in the class, that masturbation doesn't cause erectile dysfunction. Facts like that might help people to relax, and relative to their control colleagues, they might have changed their attitudes on that. When we put this into multiple regression analyses, and I apologize, Dr. Needy Coley is the superb analyst on this. She's amazing. She and all our students doing the analysis are at a conference today in Chicago, and so they can't be here. But what you see here is not only visually, the observer results are dramatic, but we have significant intervention effects on all the variables mentioned, and then an interaction effect. And just to explain that a little bit, the interaction effect was with religion, that both Christian and Muslim students increased their confidence and knowledge. The Muslim students had a significantly less increase than the Christian students, but everyone improved. So I'm going to turn it over to Dean Dixon.
Yes, thank you very much, Professor Simeon. And as I have been introduced, I'm Dixon Mkoka, Dean, School of Nursing, and a co-PI in this project. As you have been noted, that this study came up with a very interesting results. And when we were analyzing these results, we noted that the study provided a quite gold standard evidence that when it comes to sexual health, all students in the health field, the medical and nursing students, need such kind of educations. And the unique approach that we use in this study, whereby we have the medical and nursing student come together, studying, learning together, indicated that when it comes to sexual health as a health problem, you need both medical and nursing students as a future healthcare providers to be provided with such very important education. But as we have noted, that Tanzania contextual-wise is quite similar with most Sub-Saharan African countries, as well as other countries from low and middle income countries. And all this, the finding also showed that such country also need this kind of training to healthy students, because we all share most of the similarities when it comes to sexual health challenges, including misinformation on sexual health problems. And as we have said, from this study, it really implicates the approach that we used, that perhaps such kind of curriculum should be tailored in a way medical nursing students, they can just come together, learning together, both knowledge and skills, because as they go to the field after they have graduated, they all face such kind of patient, and having such kind of knowledge give them a common understanding that can help in terms of service provision, especially when it comes to sexual health. And we were very happy to know that even our students were very happy, and they really appreciated that at least they have now got a knowledge and skills that gave them confidence, as we have seen in the results as it has been presented by my colleagues in the previous slides. So we are really excited to know that such kind of approach can be adopted. And this is what we are looking forward, as Professor Simon is going to share with you our way forward after we have done this kind of a study. We are looking to see how we can expand and tailor this and scale up to other universities, but as well as to integrate to the major curriculum for the medical and nursing student. So Professor Simon, please, if you can take us into the way forward and the limitation in the way forward, you're welcome.
So the all results only, we're only reporting 3-month effects, right? And that was all we could do in the space and time of the study. And we don't know whether these results generalize to universities and other low and middle income countries, or indeed the obvious thing for United States is, do they generalize to the United States? And there's good arguments to consider there. So in terms of future directions, we're delighted to report that we put in THP2. We did mention that this was the first randomized controlled trial to NIH, and it scored very well. And our project officer has said that project officers, before it goes to council, can't tell you that it's funded. They can say, focus on getting your IRB in and getting the just in time, don't bother about doing a resubmission. So that's very, very exciting. And so I'm leaving on Monday with Dr. Mark. We're going, and Guna, because I do all this work with Guna Kelly, and she's the most amazing resource in the division. We're leaving on Monday for Dar es Salaam to start preparing for THP2. We've got 4 new aims. The first one is to fill up that gap. We're going to evaluate the medium and the long-term outcomes to see if they're sustainable. The second one is we're going to develop a training program to train faculty throughout, hopefully initially through Tanzania, and then more broadly set it up as a training program that is scalable across the continent. And then the third one is to conduct my very first phase 4 trial. I've never had something that actually warranted getting to phase 4. of our training program. And for those of you who may not be so familiar with phase 4 trials, in a phase 4 trial, what you do is you train the people at another university and see if they can replicate the results. And how do you do it in the real world setting? Your phase 3 trial is to say, what are the results in a very controlled setting? And so we're delighted that the University of Dodoma in Tanzania and the Kilimanjaro Christian Medical College University will be joining us in that. I'll be writing a supplement to have a third university. I'm particularly interested. Kilimanjaro Christian Medical College is a Christian-based university, but we have another state university of Zanzibar is in an area that is Muslim dominant. And so I'm kind of interested in exploring that and seeing how that happens. Finally, I wouldn't be me if I didn't want to lead a challenge to our colleagues. There are 5 reasons why we, as the Division of Epidemiology and Community Health, I'm going to argue, should consider doing more research in Sub-Saharan Africa. The first one is equity. We say that we're really into DEI, but if you're only doing DEI in the richest country on the world, you need to pause. There's a broader state. By 2050, 40% of the world's population will live in Africa, and yet less than 5% of the world's sex research occurs there. In terms of relevance, communities in Tanzania think that sex research is not relevant to them, and they're right. If all we do is research people in high-income countries, and then they're left to try and see what pieces of these are relevant. Young people are the most sexually active in every country on the planet, as far as I'm aware. And the average age in Tanzania is so young, 15 or 17 compared to high-income countries. There we go, 17.4 in Tanzania versus 38.1 in the US. Ethically, this is the region with the greatest sexual health concerns. And so it's also the region where public health needs to be. It's where we can do the greatest good. And scientifically, because of the impact of the internet, which may mean that our students in Minnesota are more up to date with sex education or may have got more of it in school, it's actually the area where you can show the greatest changes in the type of work that we do in behavioral education. So I'm going to say that if you're interested in possibly researching in Africa, please talk to Horatio, please talk to Kristen, please talk to me, please reach out to any of our speakers. We want to be nurturing and growing this area. That would be my argument anyway. And with that, I want to say a huge asante sana to an amazing team and amazing collaboration in Africa and in the US. And I'm going to open it up for questions.
Thank you, Professor Simon, all of your colleagues. That was an incredible amount of interesting information in a very efficient manner. So we have plenty of time for questions. I ask that anyone here raise their hand, but anyone on Zoom, because we cannot see you in this room. Some folks can see you, but the majority of us cannot. I ask you simply unmic and ask a question.
So just in case, Ruby was giving some instructions to the room, I'll repeat it for the people online, just in case they couldn't hear it. And that is that if you're online and want to ask a question, please take yourself off mute and dive right in. Questions, thoughts?
I have a question. So do you think there are opportunities to extend the research in Africa to other areas like a chronic disease?
Right. So the question is, are there opportunities to expand this work in Africa to chronic disease? And indeed, Weihang, it would be very, very easy. I know that you and I are planning a lunch together shortly, and we'll talk about that. And we can set up Zoom interviews with our colleagues. They're awesome, and we enjoy, I would highly recommend them, but there are lots of other institutes as well in Africa. But yeah, We're also going to be discussing next week possibilities of moving into training people in cancer. So it's under very active consideration. Ruby first and then David.
Work, Professor Simon. When I worked in Uganda, one of the critical questions really was with regards to knowledge and attitudes about non-HIV STIs was, look, there's only so much we can do with knowledge and attitudes when there aren't medications available, when there aren't screening widely available. So how much do you think you can move the needle by increasing knowledge and improving attitudes?
So one of the reasons that I'm really excited about this study, and I want to credit Dr. Maria Trent, she's a professor from Johns Hopkins, who encouraged us to use simulated patients to demonstrate improvements in clinical skills. I believe that you can argue that, yeah, knowledge, how much can you do with it? Attitude you can't do. But it's harder to argue that a more competent, efficient doctor who's following the law and engaging in ethical practice, I think is more solid. The beautiful thing about a lot of sexual health issues, and one of the reasons why I'm mad keen on it and have been all my career, is that you can do so much good without any medication. And, you know, any of us who have listened to somebody come and unburden something that's happened to them, sexual assault and that, sometimes just listening, there's a whole theory in sexual health called explicit. And it says that just listening can heal a lot. I would add to that, not offering medically wrong information is a really important thing as well. So, and by that, if we don't train people, then they use the prevalent knowledge in the community. And the study that Jeff published really says that doctors will say that masturbation is harmful when it's not. You know, so I think there's a big role for it. Dr. Jacobs.
Thank you. Thanks, Simon. I did put a question in chat, but I'm going to say it again here. I have read this report and I think it's really wonderful. And thank you to all the members of the team who presented. What I'm wondering about is, did you need government approval, given that it's illegal?
Mm-hmm.
And was there political blowback? And of course, I'm thinking about our illustrious country in which we're getting pretty close to that.
So when you're doing international research, there's a couple of extra layers that you need to think about. For example, for IRB, we have to run everything by 3 IRBs. I'm looking at Ali, our project coordinator, and I think she'd be tearing her hair out. But what that is that the US institution, so the University of Minnesota in this case, needs to approve. The Muhimbili University obviously needs to improve. But then the National Institute of Medical Research also reviews it at the federal or at the Tanzanian level. And that's really important. And it's important for a couple of reasons. Number one, researchers from high income countries, and perhaps America in particular, have a really bad record of doing what's called helicopter research, running in, grabbing the data and running. And the way that more and more countries are viewing it, it's like a form of cultural theft, that you take the data away. And so it's really important that Tanzania has some laws in place to protect that and to make sure that it's done correctly. Did that answer your question? Oh, apart from that,
Part of the question was there not just the IRB, but police or judiciary or something who said this?
We have not had the police visit. I had to think about, we have panels of people coming and talking about being LGBT in a country where it's illegal. So we had to think through the ethics of that. But on this study, it's been fine. Most people sort of, I suspect, think medical schools, nursing schools, education, the police aren't going to be wandering around. Now, on the study that we are conducting, Michael Ross is conducting in Tanzania with Lucy. Lucy, do you want to say your recent experience with police? Dr. Lucy,
Yeah, I'm here.
do you want to mention?
Come again?
So I'm just wondering about your study that Mike's running in Dar es Salaam. Do you want to talk about the police in that one, or would you rather not?
Oh, well, I guess it's too early to talk about that. But to answer the question that was asked, well, apart from the IRB issues, I think when you're trying to do research here, you have to also be connected to the team on the ground and understand the situation that is happening at that point in time. Currently, the study that is led by Professor Mike Ross on gay and bisexual men has encountered a little bit of challenges because at the moment, there is issues around LGBT in the country are on top of the list. Right now, they're discussed in the parliament, they're discussed in communities, they're discussed in religious institutions, as everyone is against them. So even with research, if someone does not have a clear understanding of what exactly you're doing, you may encounter problems. And that happened to us on the study site a couple of weeks ago. But the good thing is that we had straightforward documentation and we explained to them what we were doing scientifically. That was a relief to us, and they let us continue, but with certain conditions. So yeah, there are times where you may encounter such issues, and there are moments where, you know, nothing happens and everything is just fine. So you just have to be careful and liaise with the team on the ground properly.
Other questions? Are there questions in the chat, or other thoughts? Yes.
So I'm curious if you and your research collaborators have discussed any after you approach and finish your phase 2 clinical trial on this. Has there been discussion on a possible behavioral research for the impacts on patient behavior? So this is focused so much on the clinicians, which is fascinating, but I think it'd be very interesting to see if there is any measurable patient behavior outcome.
So you're thinking like an NIH reviewer. I can give it to you with 100% confidence, since that was one of the comments in the review. Like, wouldn't it be lovely if we could also find out what had happened? And I totally agree. It would be totally fantastic. The way the phase 4 trial is set up, we will have the phase 3 trial, the next one. We are going to time it so that the students get the training just at the start of their last year. They then do their follow-up just before they leave the university, so that keeps things home. And then the second follow-up, 12 months later, is after they've been in the community for 12 months. So we want to see whether that effect still lasts when they're full-time clinicians. But to actually find out its effect on patients, you'd have to design a whole nother study. And I'm not sure how that would look. It's a really good thing to do, but it may be a step where shooting for the perfect, you don't want that to defeat the possible. E.g., running a study where you went into every clinic in Tanzania would be a bit challenging, or anywhere else for that matter. I'm looking at the time. Ruby, do you want to take over from here, or how would you like to do this?
Thank you again and your wonderful colleagues. I especially appreciated the last slides, Professor Simon, on how and why it is important that we move forward with research in Africa. So I want to thank you and the team for presenting today, but also for your work and motivation for us today. So thank you so much.
Okay, so And is there any announcement about next week's seminar or?
So next week's seminar is on in-service, and we will be having someone come speak to us about.
Thank you. Okay, thank you, everyone, and thank you to those online. Really appreciate it, and have a good day.